So I'm going to talk about, I wrote a book about demystifying PANS and PANDAS. And so I always title my lectures Demystifying whatever I'm talking about. So we're going to try to demystify tick-borne diseases. I don't really have any disclosures, none that I will be talking about tonight. And there's the learning objectives. We all know the main source, the Ixodes scapularis of Borrelia burgdorferi, and Borrelia burgdorferi is one of many species, five main ones, but then we also have other forms of Borrelia, some of which we're seeing more and more of these today. Borrelia miyamotoi was first discovered in Japan in 1995, but we're now seeing it quite a bit in the Northeast. You need to understand what ticks carry. Here in the Northeast, 41% of the ticks now carry babesiosis. It's not just Lyme disease. And in fact, we really should not be talking about it as Lyme disease anymore, but more about tick-borne or vector-borne diseases. The Ixodes ticks bite a variety of hosts. So it's not just about deer. Mice, rats, squirrels, shrews, and certainly hosts like humans, domesticated animals, certainly. And then we all know there's also gestational spread and dispersion over wider distances by these animals, as well as by songbirds. I think when we talk about tick-borne disease, we certainly have to talk about prevention. Using permethrin on clothes, wet, it's toxic, but dry, it's not. And putting it on our clothes or on our shoes, there's been studies that show it decreases tick bites by 70%. And the picaridin repellent has been shown to be better than DEET repellents on exposed skin. But it's very important to remove them well and send the tick if it's found. Where I send it is to Tick Report. Often our local health departments are not testing for anything but Borrelia and only certain species of Borrelia. So we really want to get Borrelia and at least Bartonella and Babesia also. I think it's really important, and I want to thank my friend and colleague, Mariah Hinchy, for these 10 Bs. It's not just about the tick disease. It's about so many other things. Nutrient deficiencies, what's going on in the gut, what's going on in the sleep, the lifestyle. Band-aids, minimizing the symptoms. We want the child to feel comfortable. Blocking inflammation. That can be with dietary changes like an anti-inflammatory high-protein diet, nutraceuticals, herbals, and of course, medications. Dysautonomia is very frequent in our kids with tick-borne diseases. And so we need to make sure we're doing something to help this dysautonomia and buffering the autonomic nervous system. Balancing the immune system, because this is an immune-mediated disease. Building up the gut, breaking down biofilms, bolstering detoxification, binding up any toxins and treating Herx reactions, and of course, blasting the bugs. But the idea here is it's not just about blasting the bugs. It's really about a whole body multi-system approach. And another way to look at it, the spirochetes may be at the center, but it's about inflammation, the impaired immune system. Many of these children will have immunodeficiency. The microbial invasion of not just the spirochete, but also when we use antibiotics, for instance, other overgrowth, particularly fungal and other bacterial overgrowth in the gut that leads to gut dysfunction, increased Gal-3, cytokines, and altered immune response. And then there's also impaired detoxification. I would say whenever you see any of these, we should be thinking about tick and vector-borne diseases. And Joe said at the beginning, I've been treating kids with neurodevelopmental issues actually for 40 years now. I started my own practice about 26 years ago now, but I was taking care solely of kids with autism for many years. I was actually a teacher. And I used to think there was a mild overlap, and I think now they're really overlapping Venn diagrams. And we need to think about gestational Lyme disease when we have a child with autism. Certainly not everybody, but it should at least be on our minds. As sure in my dealings now with kids with PANS and PANDAS, any neuropsychiatric disease, we should be thinking about vector-borne diseases, long COVID certainly, and all the others. And again, the presentations of borreliosis are marked. And these are ones we will see in kids. We will see myocarditis. We certainly will see lethargy and fatigue. We will see dysautonomia and syncope, flu-like symptoms. But what I really see is the neuropsychiatric, the tics, the anxiety, the OCD, the PAN symptoms that we see. So yes, kids will get flu-like or GI symptoms as part of their borreliosis and the neck and joint pains. They'll also get headaches, sometimes cardiac symptoms, peripheral neuropathy, nerve pain, just like adults. But often in children, the brain fog, the neuropsychiatric symptoms, and the processing speed, the cognitive impairments are one of the things you really see. So you may see these others, but it can just be neurologic. And of course, we all know this isn't new. Brian Fallon and others have been writing about it for decades. But borreliosis is one we consider when we talk about PANS and PANDAS. There may be a rash in children, but the numbers are at most 36%. And it doesn't often look like a classic bullseye rash. It can, probably in about 20% of the kids, but it can also look very different, certainly in hairy areas and skin folds. And this was a child that the mom called me. I remember I was in the Denver airport and said the pediatrician was calling DCF because she thought he was abused. I said, that's not abuse, that's Lyme disease. And by the next day, it looked more like the classic tick-borne. But keep in mind, these can be anywhere. And then, of course, our classic Bartonella striae that we may also see. So lots of research. I have several pages of references at the end. A couple of big things I want to pull out about this. The highest rates of infection are in children 5 to 15 and those over 50. That probably has to do as much with their immune system as with their exposures. ELISA testing and two-tier testing was meant not for diagnosis, but for prevalence. And it is an insensitive way, at most 53% positivity. So, and what's also important is the weaker, the more ill a person is, the weaker their serologic response. So if we're only checking for antibodies, we may miss this. And to my point about neuropsychiatric disease in children, both Brian, Dr. Greenberg, and others have written about the large percentage of children with psychiatric symptoms with tick-borne diseases. So, and then looking at co-infections. I don't like to really call them co-infections because often we'll see Bartonella, even babesiosis by itself. But polymicrobial infections are very common, and it's more the norm in children than the exception. When we have more than one infection, it certainly increases the severity of the illness, certainly makes diagnosis more difficult. The clinical presentation may be more complex, and the lab is even less reliable, and certainly a higher risk of long-term failure rates. And a little bit about Bartonella. We certainly know it causes autoimmune encephalitis. We also know that, like in the paper written in 2012 by Sue Sweeto and others, that it is part of PANS, pediatric acute onset neuropsychiatric syndrome. So how is it transmitted? Certainly the bite or scratch of cats, saliva, claws, but cats that have been contacting dogs, it can also be from dogs. Also from cat fleas and lice, dust mites, gadflies, and there can be mother-to-child transmission with Bartonella also. There are at least 37 species, and I've listed some here. I'm not going to go through all of the different forms of them with you. You can go back and look at that. But the symptoms are very important. Again, the muscle and joint pains are prevalent. Headaches also. The slow processing speed is very common with Bartonella, even more so than Borrelia. These kids will have very slow processing. They also may have tics, twitches, fasciculations, migratory neuropathy. Those are common. And the eye findings, I'm going to show you another slide on the neuroretinitis that we see with Bartonella. But very common, and why I showed this little man on the last slide is one of the things we see very commonly is rage and aggression. And when a child has a daily flare, a daily worsening of their neuropsychiatric symptoms, Bartonella should be at the top of the list, because children with PANS and PANDAS often have episodic flares. It comes and goes. But with Bartonella, it is almost always daily and almost always with some type of rage, aggression, self-injurious behavior, or anxiety or OCD. These children will also have foot or heel pain, and the ones that are non-speaking, they may roll up their socks in the bottom of their shoes. So think about that. That may not be just a sensory issue. And then again, the striae. The striae do not follow dermal lines as they do with weight changes or with adrenal stress, etc. They're more horizontal or sometimes vertical, and they blanch. They change color when you press on them. And these striae are often on the back or the flank, but they can be anywhere. I've seen them on the forehead. I've seen them behind the ears. I've seen them on the knee. And I'll show you a picture of that in a minute. I have also diagnosed Bartonella just with eye findings, with either uveitis or a granulomatous nodule in the conjunctiva or neuroretinitis. So that is another way, if there are vision issues, to diagnose Bartonella if you have an ophthalmologist or optometrist that can do that. And then babesiosis. Acute babesiosis, of course, has flu-like symptoms, fever, chills, sweats, etc., because the Babesia parasites are infecting the red blood cells and may also cause a hemolytic anemia. The CDC talks about babesiosis chronically only in immunocompromised people. But I really believe that many of our children with other autoimmune diseases, including PANS, PANDAS, autism, etc., have a weakened immune system, at least 30 to 40% of them. And as such, may be more likely to have chronic babesiosis. So what are the symptoms with babesiosis? Certainly that unrelenting pressure headache. The dysautonomia is much greater with babesiosis than with any of the other tick-borne diseases. Night sweats, very common, either just head sweating or the total body, soaking the sheets. Rib and bone pain, air hunger, as we see with adults, can also be seen with kids. But sometimes children will just have gastrointestinal symptoms, and that's it. So you have to have a high index suspicion for these diseases and treat as such if the disease is there. We know there are many Babesia species, not just Babesia microti, but others, including Babesia duncani, and as Dr. Scott has been talking about more recently, is Babesia oticole. And that serologically cross-reacts with Babesia duncani. And we'll talk more about the testing in the next half hour with Dr. Burrascano. There are two main species in North America, but Babesia oticole, I think, is becoming more and more prevalent. Again, Dr. Burrascano will go into detail in the testings, but when I'm looking at tick-borne disease, IGeneX, not just because this is an IGeneX webinar, is my gold standard. I will do the immunoblot, and often what's called the 4B immunoblot in our area in the Northeast, which is Borrelia, TBRF, Bartonella, and Babesia. And then I will also do the fish test, Bartonella and Babesia, especially if they've been on any treatment of any kind. Quest bought the Imagen test, so does a very good job for Borrelia miyamotoi. And the Borrelia immunoblot from Quest is relatively accurate. The co-infections of Bartonella and Babesia, not accurate in any conventional lab. I will also use Galaxy for Bartonella, but I do have a few pet peeves. I think knowing the spirochetes that are most likely to be prevalent in your area is important. Ordering a bunch of tests or a huge panel may open a Pandora's box that you're not sure how to interpret. So I think it's important to do the tests that are most common in the area where the child has traveled or where you and the child live. The Lone Star tick is responsible for spreading ehrlichiosis, heartland virus, southern tick-associated rash illness, tularemia. The bites are from the Lone Star tick and can lead to alpha-gal, which is an important syndrome of not being able to handle meat that can happen. But you're not going to miss a Lone Star tick as seen here. And you only want to test if there's known exposure. So if you're in those areas of the country. There's also DNA testing, especially for acute tick bites. In addition to IGeneX Galaxy, I will also use MDL and T labs. And again, Dr. Burrascano will go over much more of the testing in detail. I wanted to talk a little bit more about treatment because I think this is very important in kids. And when I'm treating kids with any type of neuropsychiatric syndromes, tick-borne diseases, I always am using 3 modes of intervention. I'm treating the symptoms. If the child's not sleeping because of their tick-borne disease, I want to get everybody sleeping. If the child has severe ticks, I want to treat that as I'm treating the tick-borne disease. I usually start with nutraceuticals, but will sometimes use psychoactive medications as appropriate. I will also remove the source of the inflammation. That's treating with antimicrobials, either antibiotics, and I'll show you many of those, or herbals, which is often my preference in children, and very good studies behind them. And then it's very important to also treat the immune system. And using anti-inflammatory interventions. And again, herbals provide that naturally. Tick bite considerations, I think all of us on this webinar will know not 1 dose of doxycycline. I will sometimes use a homeopathic, but I do like to use herbals initially, at least before any testing. And these have been found to be very helpful. If I'm not using that, I may well use either doxycycline or minocycline, and I will order it for a month until they get the tick test back. And I may use it longer, especially if the child has any symptoms, up to 3 months, and dosing is listed there. But the treatment should include either antibiotics or herbals, and the dosing in children is by Clark's rule, which is the child's weight in pounds divided by 150. And if the adult dose is 30 drops, for instance, then it's times 30. So a 75-pound child would get 15 drops per dose. And with the herbals, we're usually dosing 3 times a day. Hard to do in kids. Often we only get in twice a day. There are other treatment options that other practitioners will use, like low-dose immunotherapy, essential oils, other immune supports, nutrition and gut healing, and lifestyle and diet management. But I'm going to talk to you about the top 2 next. Certainly with antibiotics, we know we often have to use more than 1 because we need to look at the cell wall, the intracellular, and the cystic phases. This is very difficult in children and very problematic because of the side effects we see. And there have been very good studies that herbals with Borrelia, Bartonella, and Babesia can have very good activity. Cryptolepis is the only herb tested to eradicate Borrelia burgdorferi stationary forms in subculture. And all of these herbs, Cryptolepis, Polygonum, which is Japanese knotweed, Scutellaria, which is Chinese skullcap, Juglans nigra, which is black walnut, Artemisia, Oncaria, which is cat's claw, all of these outperformed doxycycline and cefuroxime in an in vitro study. So there, and clinically, I see them work. Herbs that I also like, I want to list here with some studies that are listed in the references at the end: Artemisia, stevia, cat's claw, hatunia, atoba bark, Campsiandra, Japanese knotweed, berberine, and cryptolepis, as I mentioned. One I want to mention specifically here is stevia. Stevia is a biofilm buster. Often biofilm matrices surround these germs, especially when we're talking about chronic illness. So opening up that biofilm is important. But in children, stevia is very helpful because it also tastes good. This is stevia leaf extract, and it helps us to get some of these other herbs or medications in better when children won't take them. Now, my preference, these are all the herbs I will consider for Borrelia burgdorferi. My preference is a rotation of cat's claw, stevia, and atoba bark for 2 weeks, and then rotating that with cat's claw, Campsiandra, and stevia. And I start with 1 drop and increase up as tolerated by 1 drop per day to get to the maximum dose by Clark's rule, as I showed you. Bartonella treatment, also with antibiotics, it is at least 2 of the following, and I list several of the antibiotics that have good research behind them. Others that are being developed and also have good research are methylene blue together with clotrimazole or other azole antifungals. And I've had very good success with that regimen. But there are multiple regimens, and I've listed them all here. There's macrolide and tetracycline-based regimens, which is azithromycin or chlorantraniliprole combined with minocycline or doxycycline, but then also best to combine with either methylene blue or an herb. And in children, if I'm using antibiotics, I will usually use a combination of 2 antibiotics to treat Bartonella, and then an herb like oil of oregano or grapefruit seed extract, partially because I also am trying to decrease the dysbiosis, yeast and other germ overgrowth in the gut as I'm using the antibiotics. I may also use rifampin-based, either rifampin or rifabutin-based treatments together again with azithromycin or clarithromycin, minocycline or doxycycline, or the trimethoprim sulfa. But often, again, needs to be combined with a persister agent. And then there are methylene blue-based treatments, as I said. The methylene blue needs to be compounded and combined with one of the above macrolides or tetracyclines. And again, I usually combine it with clotrimazole or one of the other azole antifungals. But in children, I often will move quickly from antibiotics to herbals, or even start with herbals if I'm seeing a child with more chronic symptoms. And my first line is hatunia with Campsiandra and adding stevia, and I get about a 95% success rate with all 3 of those. Again, adding drop-to-drop increases up to 30 to 60 drops per day. I usually don't go beyond 60 drops total in children. Adolescents are different, but in children less than 13, usually don't go above 60 drops. And then if that does not work, I'll add Japanese knotweed, or I'll pull out the Campsiandra and add cryptolepis. And if there's no significant improvement, then I will add an enzyme to break apart the Bartonella nests or babesiosis nests. And I will always add modified citrus pectin. We know from research that decreases GAL3 and is also very good for gut health and natural detoxification. This is that one stria on her knee from Bartonella. And these are, again, many of the herbs and some of the research in Bartonella. The Babesia treatment, the classic, is atovaquone with azithromycin Clindo with quinine is an alternative choice, but one I have never used in children. 7 to 10 days, and then I will try to move on to herbals. If a child is immunocompromised, it should be extended. And in most of the children, if you're using antibiotics alone, it does need to be extended. These are the dosaging, and then I will use the atovaquone together with either azithromycin, sometimes clarithromycin, and sometimes doxy or minocycline. Atovaquone needs to be taken with fat for better absorption, and those are some sources there. Some clinicians are now starting to use tefenoquine. It is used in combination with one of the other antibiotics. It is very important to check G6PD status and be aware of the risk of methemoglobinemia. I have not used tefenoquine yet in young children and have only started to in some of my adolescents. The side effects can be severe, particularly gut side effects, but also dizziness, methemoglobinemia, so you need to follow pulse ox as well as blood testing. The herbal interventions I use, and there have been many studies that have shown this particular one from Dr. Zhang, shows that the bioactive compounds of Cryptolepis, Artemisia, skullcap are comparable to quinine and clindamycin in treating babesia. I will also add artemisinin, especially if they have a worsening around the moon cycles, and I pulse it around the full and new moon, in addition to the cryptolepis, etc. So I will often in children start with 7 to 10 days of atovaquone and azithromycin. Then as I wean the azithromycin, I will add cryptolepis and cat's claw, and then pulse in artemisia in that Clark's rule dosing, as I mentioned. So a few treatment pitfalls before I turn this over. It's a multi-system problem. Merely treating the infection does not stop the autoimmune response, and it's very important to treat all of that. Hence why I use a lot of herbals, but as I said, I will also do more to treat the immune system and the symptoms themselves. We definitely need to use food-based binders like modified citrus pectin, as I said, and we need to provide immunotherapy. That can be as simple as ibuprofen. One that I particularly like is turmeric, but there are many, many others. We need to monitor for any worsening with antibiotic use, with bloated belly, diarrhea, constipation, and evidence of yeast or other dysbiosis. We can also have secondary mitochondrial issues, metabolic issues, nutrient deficiencies, and those should be looked for and addressed when found. And I learn in pictures, so this is a roadmap that I and other clinicians often use. We want to look at their lifestyle. We want to make sure there aren't other triggers going on, virally, fungally, mold, mycotoxin disease. We want to look at nutrient deficiencies, evidence of genetic defects like MTHFR. We want to look at their gut function, their sleep, their stress, their exercise, and make sure that we're supporting them as much as possible. We need to start by doing some of those things and making sure that they're stooling well. If a child is constipated and we add antibiotics or herbs, the Herx reaction can be significant. So we want to make sure they're sweating and stooling accurately. Providing that immune support, as I said, and then providing the antimicrobials that are needed. Monitoring progress. I look for improvement. It's a marathon, not a sprint. So that improvement may only be 25% by 90 days. If we get that much improvement, we keep going. If we're not getting improvement, we'll switch up the interventions at 2 to 3 months. And we use rating scales to mark this. And then once they're symptom-free, we reverse things in the reverse order, making sure that their health is still optimized, etc., and only retest as warranted. So it's a clinical diagnosis. Go by the symptoms. It can be confirmed or not. If clinically you're sure that this is a tick-borne disease, I think it should be treated. Complete history and physical exam is necessary. appropriate Borrelia, Bartonella, and Babesia testing or whatever is prevalent in your area. I also check for immune markers, mitochondrial, metabolic, antioxidant markers as warranted, but I'm always treating my N of 1, the patient in front of me. And the treatment plan needs to include all of those things I said, and be mindful of the sensitivity of the patient. Children are often very sensitive, which is why I start with sprinkles or a drop, as I said, and make sure parents are aware of Herxheimer reaction when you get started. It'll save you a lot. And treatment is a marathon, but they can get better.
All right, so we're going to talk about testing. And as Dr. Harris said, it's not just Lyme Borrelia. I mean, IGeneX actually did a study of over 10,000 patient samples. And as you see, there's Babesia, Lyme Borrelia, relapsing fever Borrelia, Bartonella, Anaplasma, Rickettsia, Ehrlichia. But the thing is that 40% of these patients tested positive for 2 pathogens, 15% for 3, almost 5% for 4, and some even for 5. So Lyme is kind of a blanket term if you think about it, but it has to also include these concurrent infections as a potential. And when it comes to Borrelia, it's not just Borrelia, Lyme Borrelia, it's all these different ones. I want to point out one thing here. You see under the Lyme, we have in red Borrelia burgdorferi B31. This is a specific strain and species of Borrelia that was found by Willy Burgdorfer, and that's why they named it after him, back around the turn of 1980-81 from an island off the coast of New York. And he derived this not from a human being, but from a tick. Turns out that in those early days, they thought this was Lyme and that's it. And so all the testing to this day until almost recently, and all the studies of Lyme disease have been based on this one specific strain of this one specific species, which never even came from a human being. Also, this has been kept in culture in a laboratory all these years, and Borrelia especially kept in culture a long time. They lose pathogenicity, they lose some genetic material, and it's really not the same infection. But all these other ones on the list are also infecting United States patients. And the problem is that because the government with FDA and CDC only recognizes this one strain they're called B31 or Borrelia burgdorferi stricto, sensu stricto, if they're infected with one of these others and not that one specific island tick strain, you may not pick it up with these government tests. Same thing is true about relapsing fever Borrelia. You can get testing from the big labs of Hermsii, an old-fashioned IFA test, and Miyamoto, which is a very inaccurate ELISA test. But all these others have been found in the United States patients, but are not tested for. In fact, IGeneX is the only laboratory that will test for all of these things when you order their recombinant assays. And we'll go into that in a moment. Now, I wanted to talk more about tick-borne relapsing fever because a lot of people don't really know about this. Because of the misinformation. First of all, it's thought to be rare in the United States, somewhere around the Rocky Mountains and the West Coast, but it's not true. I have a map I didn't show you for the sake of time, but it's found all over the United States, including New England, New York, and all the others. It's found around the world, even above the Arctic Circle. Now, it's also said to have a distinctive clinical presentation that could not be missed. It's sudden onset of relapsing fevers, but that's not true. It can exactly present like Lyme disease and therefore not be correctly diagnosed because, as I'll show you shortly, Lyme disease tests in general don't pick up, are not designed to pick up relapsing fever Borrelia. So you can have what you think is seronegative Lyme, and in fact, it's not Lyme at all, it's relapsing fever. Also, they thought this was only being transmitted by these soft ticks, which are hard to find and not that common in the United States. But also, this is not true. First of all, Miyamoto and others have been carried and transmitted by the hard ticks or the Ixodes. And it's also been found that, at least in the southern half of the United States, the soft ticks actually are common and found even in urban areas. So how do you like that? Now, this is why relapsing fever has been ignored for so long. If you look up the textbook classic definition of tick-borne relapsing fever, they say it's recurring febrile episodes that last about 3 days, then afebrile periods, 5 to 7 days. Then you get a crisis with fever again, very high, and so forth. This is not what's been found. In fact, another study was done. 543 patients were diagnosed clinically by their practitioners as having Lyme disease. But of these, 29% were positive for antibodies to relapsing fever and not to Lyme disease Borrelia. Another cohort of this California cohort, 38% were positive for antibodies to tick-borne relapsing fever and not to Lyme Borrelia. But these people did not have this classic relapsing fever presentation. They presented just like Lyme disease. So as I said before, if you have a Lyme clinical Lyme patient and they're seronegative for Lyme, then maybe it's tick-borne relapsing fever, because none of the available Lyme IFAs, ELISAs, Western blots, PCRs, or T-cell tests have been validated for any of the relapsing fever Borrelia species. So when you're considering testing for Lyme, always add tick-borne relapsing fever as your initial diagnosis. However, commercial testing, like from the big box labs, have been validated only against two species, Hermsii and Miyamotoi, and you have to order them separately from those laboratories. And again, IGeneX, when you order tick-borne relapsing fever testing, it's broadly sensitive, will pick up those two and many, many more, because that's how these tests are designed. And I'll show you that in a moment. Now, here's some other very important facts. With tick-borne relapsing fever, if it's a soft tick, transmission is within 15 seconds of the tick bite. None of this carried, overnight, 24 hours, 36 hours, 15 seconds. Well-recognized maternal fetal passage, spontaneous abortion, premature birth, neonatal death, all have been reported from this. Louse-borne relapsing fever can be transmitted via mucous membranes. People say, gee, if there's somehow it gets in the mouth, if something like that, is that important? Or how about genitally? Well, this relapsing fever and probably others have been able to be transmitted by mucous membranes. Now, years ago, I was in contact quite often with Willie Bergdorfer, and he thought that Lyme Borrelia can also be transmitted through mucous membranes. And now we do have evidence of sexual transmission, so I guess that does carry. ARDS, acute respiratory distress syndrome, has been associated with Hermsii, and that's been reported by the CDC. Some relapsing fever species are immune evading the same way Lyme Borrelia is by affecting complement. Another thing very important, especially in the kids, you must do a cardiogram when you start your initial evaluation, because prolonged QT interval has been reported from the infection itself, and especially some of the medications and possibly some of the herbals that are being used can also affect that as well. So I always recommend you do a cardiogram first at the time of diagnosis. And in some cases, if you're using medications like the azolides or the macrolides that can prolong the QT interval, you might want to do a cardiogram once they're on treatment to be sure that you're not stirring up trouble. Now, there are a lot of pitfalls for tick-borne relapsing fever testing. As I said, the standard relapsing fever tests are not very good. For Borrelia hermsii, which is the one you can get from a commercial lab, they use a method called the IFA, which is very insensitive and also prone to false positives. The test for Miyamotoi from the big labs uses an ELISA, and in that ELISA, they only look for one protein antigen in Miyamotoi. Those of you who know about Western blots, how many bands you need. This is like having one band. How can you diagnose anything with one band? Now, the problem is that not all Miyamotoi express this one band, so you can get a lot of false negatives from this type of test. The other pitfall is that most relapsing fever Borrelia species express some antigens also found in Lyme. For example, band 41, band 23. This can give you false positive on some ELISAs because of that. So if you have a borderline ELISA on your patient, or in a Western blot, a single band of 23 or 41, that may actually be a hint that relapsing fever is present and not Lyme. So again, the solution is to also test for that. IGeneX serologies are all based on recombinant assays, and I'll explain that in a moment. So these recombinant assays get around all of these pitfalls because they're very specific for all the different species. They also offer T-cell stimulation assays, PCRs, and cultures, which we'll talk about. All right, we're going to go to Babesia. As Dr. O'Hara mentioned, there are a lot of different ones out there. You can get commercial testing for Macroti and Duncani. All the other ones have been reported in North American patients, and none of them are available with commercial testing other than IGeneX. IGeneX is capable of detecting all of these with their recombinant assays, cultures, and fish. Bartonella, the same thing. Every time I look up Bartonella, I find more species have been discovered. A count at this point is at least 45. Here's a list from Dr. Breitsroyd back in 2017. And, you can count through this list, and I count at least 15 that are known to infect humans. Now, I mentioned rapid transmission with tick-borne relaxing fever, but this is true for a lot of the tick-borne pathogens. Willy Bergdorf himself said 5 to 10% of ticks carry Lyme disease as a systemic infection, and it's in their saliva. So as they first bite and inject their saliva, they can transmit the Lyme as soon as they bite. Relapsing fevers within 1 minute or less. So one study showed 15 seconds. Bartonella is also found in tick saliva. So although studies that have not been done that I'm aware of, if it's in the saliva, rapid transmission is very likely because ticks, when they bite, the first thing they do is inject their saliva. It's an anesthetic agent that allows the bite to be painless, and it also has immune suppressive effects so that the ticks themselves are not rejected. So things in tick saliva are very, very important. Rickettsias there and arbovirus are also present in tick saliva. And Babesia, I was looking this up for this lecture, and in fact, I found that the invasion of the salivary gland by the Babesia occurs even before the feeding begins. So all these reasons are important when someone says, well, the tick was only on overnight. It wasn't the 36 hours you read about on Google. Very important that rapid transmission is a real thing. Likewise, if the tick is not properly removed, if it's squeezed or irritated, it'll regurgitate and actually put more pathogens in. You don't twist and turn, it gets pulled out slowly. And you might have to put gentle traction on it for a minute or two before it finally backs out. So don't be so thinking it's like a splint, you're going to just drag it out. Another thing, ticks, when they ingest what goes in, also comes out. And tick feces are highly infected. And often when people are pulling ticks off of animals, it gets on their fingers and then through the mucous membranes if they touch their eye or their mouth. So very important to be careful about not touching the ticks or the areas around the ticks, especially on your pets. What about the tests? There are a lot of different kinds of tests. Serologies. Serologies are made up of protein antigens from the pathogen. What does that mean? Well, the germs have proteins in them and other things that the body recognizes as foreign, and it develops an immune response against them. So serologies simply measure whether you're reacting to this pathogen. The standard serologies, the IFA, the ELISA, the Western blot, and the microarrays that Vibrant offer are basically standard. We'll go through the difference in a second. The more advanced ones are what IGeneX offers because they're recombinant. That includes a Lyme screen assay, which is their first tier of a two-tier test, the broad coverage assay, which is a replacement for the ELISA, and of course, the immunoblot, which they're famous for. One other thing, an immunoblot is a generic term for a blood test that looks at these antibodies and catalogs them individually. So technically, a Western blot can be called a form of an immunoblot. So if you see, for example, one of the big labs say we have an immunoblot for Lyme disease, don't believe it. It's not using recombinant technology the way IGeneX uses it. They're using standard Western blot technology approved by, of course, the FDA and CDC, which again uses that one tick strain, which was found from a tick from an island off the coast of New York. Another way of testing is by T-cell mitogen stimulation assay. IGeneX and Armin Labs offers this. We'll talk about that in a second. You can do a direct blood smear. That's the FISH test offered by IGeneX and T-Lab. Nucleic acid test, that's PCR. And now we have culture-enhanced PCR that IGeneX is doing that increases sensitivity by a tenfold. The droplet digital PCR is another way of enhancing PCRs, that's by Galaxy, and also direct antigen detection, which I think is very important for pediatricians to know about. There are two on the market, NanoTrap, which is a kind of a narrow test, and the dot blot by IGeneX, which is much more broad. So this is why I don't recommend the IFA and ELISA. What they do is they take antigens from the pathogen. They grow the Lyme germ, for example, in a test tube in an incubator, and they sonicate it. They break it apart and let all those antigens come out. So if you are exposed to this as a patient, you're going to make antibodies, and these tests measure the antibodies. So it only reflects past exposure, and these old-fashioned tests are not recommended because it's just that one lab strain of Borrelia, not that whole list I showed you. IFAs and ELISAs, the antigens can come from either a whole cell sonicate where all the antigens are released, or they can be specifically one thing, like the GLP in Miyamoto, or band 41, which some of the European ELISAs are using. So if you're using a whole cell sonicate, you're giving out a lot of different antigens. So they're very non-specific because, for example, in Lyme disease, if you sonicate a whole Borrelia, you're going to get not only Borrelia proteins, but proteins that other bacteria have. So you're going to have a test that is very non-specific. You can get false positives. If you use single antigen tests in your ELISA, for example, which a lot of them use only band 41, that's not only not specific because a lot of bacteria have flagella, which is what 41 is, but it's also very, very insensitive because some don't even have that band. So it's just not a good test. All right. These are not useful for early diagnosis either because they're very insensitive. It takes a long time, relatively speaking, for the body to make enough antibodies to be detected by these old-fashioned tests. The microarrays like Vibrant uses, we also don't recommend because it's basically a modification of the ELISA method where they put different antigens to small wells. And if there's a positive reaction, it fluoresces, it glows in the dark. The machine reads that. So this is subject to calibration issues. How much fluorescence is required to be called positive? Are the antigens accurate? Well, they're from lice organisms, or they're individual antigens. And so far, published data from this lab has shown the sensitivity comparable to the two-tier method, which shows between 50 and 57% sensitivity. Or in other words, you're having false negatives, 43 to 50% of the time. You're basically a coin toss. Clinically, we also find it's very low for specificity as well. Now, the other thing about these, which is another big problem, the results are not based on finding the germ or finding something concrete. They're framed around a statistical cutoff. So what they do is they use controls and they find what's positive and what's negative, and they use mathematics to find what they should use as their cutoff. A good lab will use a positive cutoff that's 3 standard deviations above the negative control, but some labs use 2 standard deviations. A borderline in the better labs is 2 standard deviations, and some labs use 1. So this cutoff is an artificial number, and there's always a trade-off between sensitivity and specificity. Now, borderline results, they only mean uncertainty. It's an increased chance of false positive if you rely on a borderline test. So it suggests that you need to do a more specific test or look for different pathogens or perhaps even autoimmunity, because some of these tests will react to autoantibodies. Another reason why we don't recommend a Western blot is because it's not very specific. Here we have picture of what the Western blot. What they do is, again, they take a whole spirochete in Lyme disease, we're using that as the example, and they break it apart into zillions of little pieces. They subject it to electrophoresis to separate out these antigens, and they put it on the test strip. When the patient's serum is added, if there are antibodies to these antigens, you get a dark spot, and that's what they call the band. Now, the location of these bands on these strips, it's based on where they moved with the electrophoresis and how they compare to the test strip. So if you look at the picture on the far right, that's the control, and here are the patient ones, a little bit to the left of them. And you see some bands, and they kind of line up. Some of them don't line up, and some of them are very dark, and easily you can say they're positive. Then what about the faint ones? Are you going to call that positive? Who's to decide? Some very simple things that you do, like changing the temperature of the bath or the salt content in this electrophoresis can change what this looks like. So it's very non-specific. So when you're releasing all these different bands, you're also releasing things that can co-migrate or co-react to things from viruses, for example, other bacteria. The test is based on a culture of a spirochete. How good that culture is determines how strong these bands are. So basically, you have a test that, although better than an ELISA, is still one species, it's poorly sensitive, and not very specific. So what IGeneX has done, which has kind of revolutionized serologic testing, is they use recombinant antigen assays. Now, what are these? All the serologies, the Lyme screen assay, the broad culture assay, the AccuDot, which is the at-home test I'll tell you about, and the immunoblots. These are replacing all those other standard old-fashioned tests. Here, the antigens don't come from busting up spirochetes or other bacteria or parasites. What they do, they create specific antigens in the lab so they're absolutely specifically what they want. What they do, they reverse engineer the bacteria. For example, they'll say, all right, we want surface protein 23. So they look at the genes in the bacterium that makes that protein, and they use a viral vector to infect E. coli to produce these in very high quantities and in very high purity, which is then purified even further. Then instead of using electrophoresis, which is inaccurate and inexact, they use an inkjet type of printer to print these things on the strip. So they know exactly what the dots are, what numbers they are, where they are located, how strong they are, and so forth. Clinically, it's the most sensitive serological method you can get. Can be used in all stages of illness, even early disease, established and chronic. And in fact, clinically, we've seen positives in just 2 weeks after exposure. Another thing is these tests can be done while on treatment. Now, there are false negatives, even to good tests like immunoblots. Now, why is that? Well, one is if you use an old-fashioned test, an insensitive test, or the cutoff is calibrated poorly. If you don't use a recombinant assay, an old-fashioned one, if you do the test before the 4 to 6 week point, you have a good chance of getting false negatives. The other thing is tricky. These tests measure the levels of antibody freely in circulation. But the problem is antibodies can be trapped in immune complexes during antigen excess. Antigens and antibodies combine together. So if you have a lot of antigen, a lot of bugs, and you don't have that many antibodies left, the antibodies will be attached to and sort of sucked up by these immune complexes, and there's no free antibody left to test. So this is why some patients who initially are seronegative, you treat them a bit, they start to feel a bit better, you start to see a response, and you test them again, and now they're seropositive. It's because, number one, you've broken up the immune complexes, and number two, maybe you've started some healing of their immune system. And that's the other thing. Immune dysfunction can be pre-existing, and maybe that's why some people are sicker than others, or it can be a result of the co-infections or the concurrent infections. All three of the big Bs, Borrelia, Babesia, and Bartonella, all are potentially immunosuppressive. That's been reported in the literature. And finally, testing for the wrong organism. We know how the symptoms overlap. You can confuse Lyme with Bartonella, relapsing fever with Babesia, and so forth. So testing for the wrong organism is an obvious problem. The T-cell test, what is that? If antigens are present, our T cells will activate. If we get exposed to a bacterium, our T cells activate against that bacterium. So this test measures that activation. Again, it reflects past exposure. And for a lab to do this properly, you have to have the patient's T cells, the blood is drawn, the T cells have to be kept alive in transit to the lab. That's why you don't want to send these overseas. And it's put in cell culture. And then the antigens of the organism are introduced. And if the T cells had been exposed from a prior infection, they'll activate and they'll release interferon, and that's what's measured. Now, this is very sensitive, very early, the first 2 weeks, but then the sensitivity falls off. However, in very late chronic disease, the sensitivity starts to increase again. But the nice thing is that T cell responses are independent of B cell responses. B cells do the serologies, T cells do this test. So you can have someone who's seronegative on a B cell test, but they can be positive on this. IGeneX goes one step further. They develop their tests, their T cell tests, to detect these bacteria and pathogens at the genus level. So it's not just Borrelia burgdorferi, it's all the Borrelia. It's not just tick-borne relapsing fever, it's all the relapsing fevers, broadening the coverage. Now, if you use this test in the specific time window, the first couple of weeks or in late chronic disease, you probably could get as good as an 80% sensitivity and specificity. Other than that time window, you're probably not going to get a good result of this. Therefore, again, if someone has B cell dysfunction or very early and very late, that's when this test can be done. The FISH test, it's a fluorescent in situ hybridization assay. Basically what they do, they take the patient's blood, put a drop of blood on a slide, they use a special stain, and they look under the microscope. Sounds old-fashioned, but actually it's not, because it's not just a dye. Use an RNA-specific probe that's specific to the pathogen, and that probe is then bound to a fluorescent dye, and it's put under a black light under the microscope. So this increases the sensitivity of a blood smear from a standard stain to a FISH by 100 to 1,000 times, depends on which literature you read. Another thing very important, this can detect organisms even if they're embedded in a biofilm. That's why it's available for Babesia and Bartonella. Again, it's genus level detection, so it's going to broaden the species coverage. That's what IGeneX does. And the other thing is that they've done a number of validation studies, and it's 100% specific. You'll not have a cross-reaction with other tick-borne diseases or even malaria, not with toxoplasmosis, none of the other protozoa. So it's a very specific test. You get a positive, you believe it. Now, The pathogen load is high early in the infection before the immunity develops, so a positive can appear very early, matter of fact, the first few days of an infection. The pathogen load also increases very late in the infection as the immunity declines and then organisms adapt to the host, they grow back. So very late in disease is when it can be very helpful. And again, it's very specific. So you may not get a positive because you don't always pick them up with a blood test, but if you do get a positive, it's absolutely something you should believe. The PCR test is very poorly sensitive when done on the blood. Okay, it detects the patient's nucleic or the pathogen's nucleic acid in the patient's blood, and in this case, it's DNA. The problem is that there are a number of things in the blood, such as host DNA, heparin, other things in the blood that inhibit the actual chemical reaction of the PCR method. So blood sensitivity is very, very low. However, it is very highly specific. So a negative PCR doesn't help you. A positive means you probably really have it. Other thing is, though, you can test other body fluids like spinal fluid and urine. These have inhibitors, not as many, but they do have inhibitors. Biopsies have no inhibitors, so the yield there is much higher. For example, if someone does a synovial biopsy or a skin biopsy or a biopsy of the placenta, then the PCR is a reasonable test. Again, IGeneX, when their PCRs are done, they're done at a genus level to broaden coverage. And what they do for increasing sensitivity, they take the blood and they'll test both the whole blood and the serum separately. And when Borrelia is concerned, they'll also do 2 different probes on each to test for plasmid and chromosomal DNA. So for Borrelia, you're getting actually 4 PCRs in one. And these PCRs are available for Lyme and relapsing fever, Babesia, Bartonella, and plasma ehrlichia, and for the rickettsias. So a couple of enhancements that are done to try and get the PCRs to work better. The droplet digital PCR is one that takes the blood and breaks up into many, many samples, many, many droplets that are individually tested. It doesn't do anything to get rid of the inhibitors, but it does increase the odds of getting a positive. The other way is pre-culturing. What IGeneX does is what they call the CE or culture enhanced PCR. The blood is kept in an incubator for 2 weeks, let the organisms grow a bit, and then the PCR is done. At the same time, there are processes to remove these inhibitors. And sensitivity is increased over a standard PCR by at least a factor of 10, and I've seen numbers even higher than that, but at least a factor of 10. Galaxy offers this for Bartonella. IGeneX has it for Lyme, relapsing fever, Babesia, Bartonella, and the rickettsias. As I mentioned before, urine testing is something that I think is really helpful for the pediatric group. In Lyme disease, during an active infection, Borrelia antigens and sometimes even whole spirochetes can be found in the urine. So this test is a direct assay, it also can be done on spinal fluid to detect these antigens. Unfortunately, it's only Lyme disease. It's not any of the other tick-borne pathogens. And the 2 that are available, IGeneX has what's called the Lyme dot blot. Sensitivity is at least 70%. Specificity is very high. However, if there's a urinary tract infection concurrent, then that can give you a false positive. So basically what you do is you do a urine culture when you do this, just to be sure. The beauty of this is it is multi-species and multiple antigens, 31, 34, 39, and 93 are the key antigens that are specific to Lyme Borrelia. Galaxy offers a nanotrap. They only use 1 antigen now, 31, so the sensitivity is not as good. This is really helpful when it's impractical to draw blood, poor access, newborns, young children, kids who don't want to get needle stuck. Clinically, the thing is, antigen spillage is not constant. It varies a lot. There can be days when nothing comes out and days when it's huge quantities come out. And the spillage of antigen, and therefore the sensitivity, tracks the symptom severity. During symptom flares in Herxheimer's and in hormonally active women with their menstrual cycle, that's when the spillage of antigen is highest. So to increase sensitivity in untreated patients, what clinicians generally do is they pre-treat with antibiotics to induce a Herxheimer. So for example, medications days 1 through 5, then you can test on days 2, 4, and 6, you can collect 3 separate urine samples. If someone's already been treated, you can then collect samples on different days during a symptom flare. And this is why it's also good, because you can test while someone is on treatment. And again, not all 3 samples may be positive, and you believe the positive ones. I want to talk briefly about the immunoblot that's been now cleared by the FDA because we're running out of time. CDC made 2-tier testing for Lyme. The idea is you have a first tier, a very sensitive screening test to pick up everything at the risk of some false positives. Then if that's not positive, you forget about it. But if it is positive, you do a second test to try and confirm it. Well, the first test has to be 99% sensitive for this to work, and the second one has to be just as sensitive, but 95% specific. In Lyme, they use the ELISA, 50% sensitivity. The second tier, the ELISA is tier 1, and the second tier is a Western blot, which is just very much, not much better. And overall, you're getting 50 to 57% sensitivity. Also, when they do a Western blot, CDCs um, tell you which bands, which antigens on the Western blot are important. And they give you 10 different bands, and then you have to 5 out of 10 on IgG to be positive. The problem is the bands they list, 18, 28, 30, 30, 41, 45, 50, 7 out of the 10 they list are not specific to Lyme. You can get such false positives from this, it's ridiculous. The 2 bands that are very specific for Lyme, 31 and 34, were excluded. And finally, to make it even worse, only one strain of one species. Again, that lab strain B31, which came not from a human, but from a tick. What IGeneX has done, which got them the FDA clearance, is that in the immunoblot, it includes the LSA to serve as tier 1, which is also a recombinant test. An immunoblot is 2, it's tier 2. It includes bands 31 and 34, so it's much more sensitive. It does not use any of the non-specific bands, so it's much more specific. And the interpretation is not 5 out of 10 bands, but IGeneX's 2-band criteria. And finally, it's multi-species, like I've been saying from the beginning. Just a quick to show you what this looks like. When you do the interpretation, I say it's 2 bands, but they call them band groups, because instead of having one band 23, they have 9 different band 23s, 9 31s, 2 39s, 2 41s, 2 different controls. In addition to the controls, it's 31 different bands, and you need just from 2 different groups. Now, why do they have 9 of these, and why do they have 9 of those? Because it's different species. That's how they make it so much more sensitive and so much more accurate. Now, the FDA clearance means now commercial labs, such as LabCorp, your local hospital, they can buy the immunoblot from IGeneX, or the company that IGeneX has formed for this, and actually offer the immunoblot, the IGeneX immunoblot in their hospitals. So what we need to do, if at all possible, is campaign your local hospitals and your local labs to get these kits and to start to use them. In fact, this is so accurate, they call it the IDART test. It's so accurate, it forced the CDC to change its laboratory criteria for the diagnosis of Lyme. And in fact, if you go to the webpage, they no longer say all those non-specific bands. They no longer say 5 out of 10. They no longer talk about excluding 31 and 34. All they say is use a test that's FDA cleared. So here we go. That's it. Big win. We've been fighting this for 35 years. Before I close, I want to talk about the AccuDart. It's a home test kit that you can do. It's very accurate, and all it takes is you can get this without a doctor's prescription. It's based on the IGeneX broad coverage assay. What does that mean? It's recombinant technology, multi-species, and what it does is it takes the information from an immunoblot and just strips it down to the basics. It's a yes or a no. It doesn't say IgM, IgG, what bands, whatever. No, it's either you have it or you don't. It's very clear. They've found on testing that this has a sensitivity of not 50% like an ELISA, but 83%. In fact, the only test more sensitive than this is the immunoblot itself. And you can get this for Lyme, Lyme Borrelia, relapsing fever Borrelia, Babesia, and Bartonella. You get them online without a prescription. It's a single, you get the kit. It's a finger stick. Then you send it back to IGeneX where they process it. Practitioners can stock this in their offices, which is great if you don't have a lab nearby or in your office and you want to do testing. Patients can order them and do the kits and their tests at home. They don't have to go to a lab or an office. And that's great if you have a new patient waiting to get seen, or if it's between visits, if they don't want to come in. It's great for telemedicine. Also, very often there's a family dynamic where one person says, I have Lyme, and my spouse or my sister or whoever, I'm sure has Lyme, but is in denial. So they can get the family tested. They don't have to go to a doctor, go to a lab. They just order a kit and get it done. Now, if you get a positive and it says yes or a no, if you get a positive, you say, well, let's see what species. Let's see if it's an IgM or IgG. Then you can get an immunoblot to get more results out of it. But still, it's a good standalone test that's easy to get and easy to do. When you do an indirect test like serologies, you want to do when the immune response is strongest. You can do them when they're on antibiotics. And the problem is in late infection and immune deficiency, the tests may not be as sensitive, and that's why we add other tests to it. The direct blood tests, like the culture, the FISH, the PCR, the test is best when the pathogen load is highest, early in the infection and during symptom flares. Antibiotics here can, and antimicrobials from herbs can decrease sensitivity, so it's best to not do this one on treatment. And the urine test, again, it's an important test. Antigen spillage and the sensitivity tracks the symptoms. Symptom flares in Herxheimer's and during menses, that's when it's the most sensitive. So as I said before, you can pre-treat. You can do it for people who are having a symptom flare, even if they're on treatment. As long as there's no UTI, it's fine. Do a urine culture. Unfortunately, it's only for Lyme. Early illness, antigen capture for the Lyme, for the urine. The FISH test with bees and Bartonella, very good at early disease. Immunoblot is the only real serology you can get that's positive as early as 2 weeks. In fact, CDC testing found a 93% sensitivity of IgM and IgG combined at early Lyme disease at the time of an asymptomatic rash. There's never a test for early Lyme that had 93% sensitivity. So that's a good thing to remember. T-cell tests, as I said, are good for early disease, and pretty much that's it. And the culture-enhanced PCRs, again, early in the disease, PCRs are helpful if they're enhanced by the culture. Disseminated disease, AccuDart and Immunoblot are the way to go. Antigen capture as well. The direct tests like FISH, less likely to be positive, as are the PCRs. But in the chronic illness, 6 to 12 months when the immune system's breaking down, you need to do everything. You need to do the serologies and the direct tests and the urine capture if you can, because some people have testing in one and not in the other. Immune deficiency likewise. This is interesting, a little aside, I want to take a moment. If someone's immune deficient, I favor doing both a B cell test like an Immunoblot and a T cell test like the T cell response assay, because not only are you doing a diagnostic test for pathogens, you're also diagnosing the reactivity of the person's immune system. If they don't have an Immunoblot positive, but the T cells responding, you know there's a B cell deficiency, and so on it goes. So I find this useful to help categorize the patients. And it's something you can do from time to time to see healing, because as people heal from these illnesses, their immune system recovers and the testing, which was negative, can become positive. Gestational, Immunoblot for the mother. Always test the placenta by histology. Get the pathologist to do it. Look for inclusions that are highly related to autism as a risk factor, and also test it for PCR or by PCR for the different pathogens. Newborns, again, the cord blood for culture enhanced PCR by IGeneX, and a urine antigen capture and urine PCR at birth. And then what I would do with my children, my newborn patients, let's say the initial testing is negative, the patients seem healthy and fine, they're developing well. I would still do a simple urine antigen test once a month for the first 6 to 12 months, just to be sure things are good. And there are times when they would look fine, and by month 4, they're starting to get positives, and sure enough, you jump on it quick before they start to get really sick. I have a testing summary I'm not going to go through right now, but again, these slides will be made available to you, where it talks about the difference of direct testing and indirect testing, what they are, when to use them, and gives you examples. And finally, the last slide is a testing guide, what the different tests are, what their features are, when you use them, and what the accuracy is like. And it goes through the simple serologies, the more advanced serologies, T cells, PCRs, cultures, FISH, and the urine test. And I think I got done only a little bit over time. All right, so I'll stop sharing my screen. All right, we're back.
Thanks, Dr. Burrascano, for packing so much information into a short amount of time. Yeah, we're a little bit long here, but I think we have time to take a couple of questions. If you do have a question, please enter it into the Q&A box. Should be at the bottom of your screen. We won't be able to get to all of them, but we'll certainly follow up after in the coming days to answer all these questions. But we'll take questions for maybe 5 minutes, and I'll start off with one here, maybe for Dr. O'Hara. Do you see mold toxicity often with chronic Lyme disease? And if so, what do you recommend for treatment?
I do. Yeah, I do see a lot of mold, especially in this area of the country, not just with children with chronic Lyme, but absolutely mold can be one of the toxins in the background. I think one, You need to see where the exposure is. If it's in the home, remediate as much as possible. And it is important to know this is not just old homes, it can also be new homes, especially homes built since COVID, because a lot of the particle board was moldy because of our supply chain problems. So remediation is number one. The second is I use a lot of modified citrus pectin as a food-based binder, much more so than charcoal or other binders. And this works very well for tick-borne disease as well as mold. The next thing is that mast cell activation, often a part, cytokine storm, et cetera, of tick-borne disease, but also part of mold. So antihistamines, mast cell stabilizers, medications like cromolyn sodium, or nutraceuticals like quercetin can be very helpful. And then finally, antimicrobials like antifungals, oil of oregano, garlic, grapefruit seed extract, or antifungal medications. And I have a great health coach, happy to share, and people that do remediation well for anybody in the Northeast. So
Excellent. Thank you. Another question, is there a single test we can order that includes all pathogens, Lyme disease, Babesia, TBRF? Dr. B, I don't believe there is, but that would be great if there were.
Yeah, it would be great indeed. But, they are different pathogens. They do different things in the body. They are found in different parts of the body. And so different test methods have to be employed. So it'd be great to have one blanket test, but there isn't. So what IGeneX has done is they've created what they call test panels, like TBD4, TBD5, TBD6, that include the most popular groupings of tests. And I don't work for IGeneX, so I don't know the details, but I believe that these test panels offer a substantial discount as compared to ordering tests individually. So you can talk to the IGeneX sales reps or just call IGeneX, and they'll probably fill you in on the best panels to use for your clients.
Okay, excellent. Another question, let's see. For patients who are recently bit by a tick but asymptomatic while waiting testing, do you begin testing all the factors of gut health, immune function, and begin treatment, or wait until test results come back? So do you begin treatment or do you wait for
I
the test
only
results?
begin treatment for the possibility that the tick is infected with spirochetes. So as I said on that one slide with either herbals or doxycycline, I don't go through everything else until I know I'm going to be on a more prolonged course. So the other factors I'll do later. But if they're already a patient of mine, I'm already addressing those. So anyway.
Okay, excellent. And maybe one more here. I know we have a number of questions we won't be able to get to. Again, you can write them in the Q&A box and we'll follow up after this week. And the slides and the recording will be on the IGeneX website by Friday. But one question here that we get a lot at the lab is, what is it about the immunoblot test? We have immunoblots for Lyme, TBRF, Babesia, and Bartonella. What is it about that test that makes it popular with your lab? It's a question we constantly get. Dr. B?
Well, the test is more sensitive and more specific than any other serologic test. It's based on recombinant antigens, not ones derived from different germs. And it is very easy to interpret. They also have the ability to, at least to some degree, name the different species. It might show, for example, Babesia duncani or Babesia microti. And so it's useful because it gives a lot more information in a much more accurate way. One other thing is sometimes immunoblots, they'll say positive, but we can't tell you the species. It's unspeciated. Well, it doesn't mean it's a negative test. It just means that it's either a species that is not on the list, it's an atypical species, or that sometimes people are infected with two or more species of the same organism. Like you can have microta and duncani, you can have several Bartonella at once. And sometimes when you have more than one organism, you won't be able to identify them individually. So they just say it's a positive test, but I can't tell you the species. So it's popular because it's of its accuracy and because it's so inclusive.